Hello everybody, this is Dr. Nadeem and we are with Neelam Path lecture series, the PALM series group, which is practical aspect of lab medicine. As you are aware, all our lectures are available on YouTube. We have a Telegram group which you can join this group for accessing all lecture related information. We have a Google Drive where the PDF of all lectures are available and a master integration key by which you can navigate between the PDF and the YouTube. We invite all interested experts who want to take lectures on this platform. They can write to us and we will definitely give them an opportunity to talk on this platform and to teach people all across the globe. These are the disclaimers. Here we would like to specify we do not sponsor any company, group or organization. Any reference is purely to make us understand the topic and not to subscribe any brand. We are with phase 3, which is recorded pathology lecture, and we are with PALM-08. We are streaming from RG Kar Medical College. The topic of the day is biological variation. And to talk on that, we have Dr. Sharmistha Choudhuri, who is an MBBS, MD from AIIMS, New Delhi, Diploma in Health and Family Welfare, New Delhi, Assistant Professor in the Department of Biochemistry, RG Kar Medical College and Hospital, Kolkata. She is an Assistant General Secretary of SACLMP, member of the editorial board of the Journal of Applied Biochemistry and Laboratory Medicine, member Medical Education Unit, RG Kar Medical College, member Scientific Committee of RG Kar Medical College, Technical Assessor NABL, published various articles in national and international journals and has been actively participating as guest speakers in various CMEs and conferences across the country. With this, I would request Dr. Sharmistha Choudhuri ma'am to start her talk. Over to you. Thank you so much.
Good evening, and thank you once again for having me here as part of the PALM module, that is the practical aspects of laboratory medicine. Thank you so much, Dr. Nadeem. It gives me great pleasure to bring forward another addition to the PALM module, the biological variation. Now, we have a very common saying in our clinical chemistry adage that no result is always better than wrong results. So coming to the basic tenets, all clinical chemistry measurements, they change with time, and the knowledge of temporal changes is very useful in the diagnosis and the interpretation. And this rate of change may also be extremely useful in predicting the prognosis. An understanding of the sources of biological variation, in particularly when it comes to the non-diseased individuals, is fundamental in the development of reference data. Say we want to go for verification of some biological reference interval, or we want to validate or even establish a biological reference interval, then it becomes very difficult if we do not negate the effects of biological variation in that data. So we have to have a thorough knowledge of this. So what actually do we look for? First of all, it is very important to identify the exact nature of the variation and also to understand the significance of this biological variation in our actual measurements. What we analyze in our autoanalyzers or semi-auto analyzers, everything is affected by some variation which is attributed to some biological factor. And it also helps us to attain the insight into the determination and application of indices of the various biological variations. So coming to some of these pre-analytical factors, there are some factors which influence and there are some factors which actually interfere. So influencing factors, these are most commonly in vivo factors. They are internal factors, but they can also occur outside the body, that is in vitro, particularly during the transport and storage of biological samples. And it changes in the quantity of the analyte. It is method independent. So even if we change the analytical method, we may not be changing the influence of this particular factor. And it consists of controllable and non-controllable variables. Now, what are the controllable variables? For this, let us go one by one. There are a huge number of controllable variables, so we'll go one by one at a time. So first and foremost, coming to the timing of sample. What is the best time of the day? What was the time after the last meal? What was the time after the last sample? and what was the time after the last dose of a particular drug. These things are very important. First of all, it is very important to know when is the best time for sampling. If the influence of the meal is going to be significant, then the time after the last meal is also very, very important. Say we want to go for a lipid profile or a blood sugar, then the last meal becomes very important. Particularly the quality of the meal is also a determining factor. Apart from this, of course, if drugs are going to be an influence, then the timing after the last dose of the drug, that is also very much significant. Now, influence of the circadian rhythm. This is particularly a problem when it comes to hormones. So analytes can fluctuate in plasma levels over the course of a single 24-hour period. Examples of such analytes include potassium, cortisol. Circadian rhythm is also influenced by individual responses to meals, exercise, sleep, and this should not be confused with actual circadian changes, which are independent of meal timings, which are independent of sleep timings or sleep duration, which are independent of whether the individual has exercised or not. And apart from this, there is also the question of seasonal influence. For example, the total triiodothyronine is 20% lower in summer than in winters, while it has been seen that the 25-hydroxyvitamin D higher levels are seen during the summer months than during the winter period. The third important influencing factor are the phases of the menstrual cycle. Now, it has been seen that there is reduced phosphate and iron in the serum during the menstrual phase. During the pre-ovulation phase, there have been increased levels of aldosterone and renin, and during the luteal phase, the cholesterol levels are less. So it is very important to know that in which phase of the menstrual cycle the lady is, because that can have a direct bearing on the different biochemical parameters. Then comes the very important role of diagnostic and therapeutic procedures. Whether the person is about to or has undergone some operation, whether there has been some physical stress, for example, after treadmill testing, if one assays an analyte like the creatine kinase, it is bound to be high. Whether the person has received some kind of infusion or transfusion. If a person is receiving infusion of sodium chloride and the sample is drawn from that line, obviously the electrolytes will not be optimum. There will be a false value because of the hemodilution. If the person has recently received blood transfusion, the red blood cell indices will be totally different. Then coming to function tests like oral glucose tolerance test. For this particular procedure, it is very important to educate the patient before the test. How much carbohydrate intake they should be taking 3 days prior to the test, at least 150 gram, that they should abstain from smoking, they should abstain from alcohol consumption of stressful activity the day before the test, as these are known to falsely induce hyperglycemia. Then for procedures like endoscopy and dialysis, whether if a person has undergone that and the dialysate is sent immediately after the particular procedure, then obviously we cannot expect the electrolytes at that time to be normalized. Then if a person has received a contrast media or certain drugs or ionizing radiation, if a person is under mental stress, then hormones like cortisol, they are bound to be elevated. So we have to take these things into account also prior to sampling. The fifth important thing is very, very crucial, that is diet. What type of diet the person consumes. If it is a protein rich diet, if it is a fat rich diet, if it is a carbohydrate rich diet, automatically various analytes are affected. If it is a vegetarian based diet, so then in pure vegetarians, automatically B12 levels are less, because the sources of the non-veg food, that is the only source of vitamin B12. So for these factors also, we have to take into account what type of dietary practices the individual is engaging in. Just for examples, it has been seen that in a protein rich diet, there is always a tendency to have higher urea and creatinine and uric acid long term. Then in case of fat rich diet, obviously is very obvious. There will be a rise in the TG level, there will be a lower nitrogen pool, and there will be a high ratio of the poly versus the mono unsaturated fatty acids. LDL may be low, may be high, depending on what type of fat is being consumed. If the diet is very rich in the polyunsaturated fatty acids, usually lower levels of LDL cholesterol are seen, vis-a-vis if the diet is rich in saturated fats, then higher levels of LDL cholesterol is seen. HDL remains variable because HDL levels are mainly influenced by exercise rather than actual dietary practice. If the diet is particularly rich in carbohydrates, serum proteins may be somewhat lower. And if the diet is very rich in carbohydrates, automatically the carbohydrates, the unutilized carbohydrates, they get converted to fats. And at the same time, that leads to higher TG and LDL with starches. While if the diet is rich, not in the refined carbohydrates, but more rich in the dietary fibers, automatically lower levels of LDL are seen. And in case of a vegetarian based diet, a vegan diet, lower TG and cholesterol is seen, while the urine pH becomes somewhat elevated. So according to the dietary practices of the person, biochemical analytes are largely influenced. So this is a chart just which shows the change in the serum concentration of different analytes 2 hours after a standardized meal. Particularly, the biggest influence is, as expected, on the triglyceride levels. The sixth thing is the fluid intake before sampling. Which fluids in particular? One culprit is the caffeine, the other is, no surprises there, alcohol. So a diet which is very rich in fluid caffeine, you can see from the picture. What is the influence of caffeine? Number one, caffeine is a sympathetic stimulant. So immediately if one takes caffeine, one can expect a sympathetic overdrive, and there is rise in the catecholamines. Apart from this, there is rise in free cortisol and the 11-hydroxycorticosteroids. There's increased metabolism of glucose and lipid catabolism that leads to elevation of the plasma free fatty acids, and there is elevation of blood glucose too. Because of the sympathetic overdrive, there is rise in renin activity, and the renin, angiotensin, aldosterone system, they get activated, which leads to increased electrolyte excretion and increase in the urine output. Moreover, caffeine directly stimulates the gastric parietal cells to secrete acid, and there is also rise in the gastrin from the G cells as well as pepsin from the stomach, and this leads to an acidic overdrive. Now coming to the influence of alcohol, which is quite paramount. It has some acute effects and some chronic effects. What are the acute effects of alcohol? The reduced blood glucose and increase in the blood lactate, because as we know, alcohol metabolism, it leads inevitably to formation of acetaldehyde and acetic acid, and as a result there is an overproduction of the NADH because of the oxidative process, and to regenerate the NAD, that is the oxidized form of the NADH, one has to lead to something getting reduced, and that which gets reduced is the pyruvate to the lactate, and so there is an increase in the blood lactate. Moreover, this blood lactate, it competes with the urate for excretion, and in that battle the lactate actually wins, and the urate remains unexcreted, accumulates in the renal tubules, and often precipitates in the form of urate crystals and urate stones. And this is extremely common in chronic alcoholics, particularly after an acute episode of binge drinking. And what else is common? Reduced serum bicarbonate, because with the too much of the lactic acid being produced, the pH invariably drops, and the severity, whether it will lead to actual acidosis or not, that depends on the amount of alcohol ingested, which naturally that is directly proportional to the amount of lactic acid generated. Furthermore, there is increased activity of the gamma glutamyl transpeptidase enzyme and reduced activity of Krebs cycle enzymes like isocitrate dehydrogenase, because in acute alcohol intake the Krebs cycle is compromised and mostly anaerobic glycolysis occurs. The brain, which is totally dependent on the Krebs cycle for its energy needs, does not get adequate energy because the Krebs cycle remains compromised, and that leads to all the mental effects, the altered mentation, altered sensorium seen in acute alcohol intake. That's largely responsible for that is the compromisation of the TCA cycle. Now coming to the chronic effects, hyperprolactinemia is commonly seen in chronic alcoholics. There is suppression of the gonadotropin secretion and loss of the gonadotropin reserve. There's hyperactivity of the hypothalamic pituitary axis and hypercortisolism. And there are several markers which are very commonly seen elevated in chronic alcoholics, like the carbohydrate deficient transferrin, the GGT, the mean corpuscular volume. These are all very time tested markers of chronic alcohol intake. The seventh factor, the influencing factor, that is smoking. So with smoking, it's very easy to delineate exactly after which time point which type of effects are likely to occur. So within 10 minutes of the smoking, there is rise in the blood glucose by at least 10 milligram per dl. Within 1 hour, there is rise in fatty acids, cortisol, aldosterone, epinephrine, free glycerol, triglycerides, LDL, cholesterol. The list is pretty endless. Chronic effects of smoking, they affect the blood cell count, particularly the leukocyte count. They affect lipoprotein levels, hormones, vitamins, tumor markers, all are affected. There is high propensity to develop increased levels of carboxyhemoglobin because of its affection of the leukocyte count. Because of leukopenia, there is compromised immunity, and it also affects the sperm count, leading to infertility. In heavy smokers, there may be a rise in the total leukocyte count up to 30%, and particularly in the lower respiratory tract. And there is also increase in the carcinoembryonic antigen, or the CEA. And this we have to keep in mind, particularly if we are, since CEA is a tumor marker for colon carcinoma, elevated levels, falsely elevated levels may be found in heavy smokers. So this we have to keep in mind while assaying for the analyte. The eighth factor is body position and tourniquet. Change from supine to upright posture increases the concentration of all the constituents that do not pass the capillary filtration barrier. And this includes small molecular weight substances which are bound to protein. Example, free calcium does not change, whereas the total calcium increases by 5 to 10%. Why? Because a significant portion of calcium remains protein bound. So it is that fraction which shows an elevation, but not the free calcium. Blood sampling should preferably be performed after at least 15 minutes of rest in the supine or sitting posture. Immediately after changing the position, the blood should not be drawn. At least a gap of 15 minutes should be maintained. When we come to the question of the application of tourniquet, a tourniquet is always desired by phlebotomists. Why? Because it gives a prominent vein easy access for venous puncture. But what are the flip side? What are the down effects? The application of tourniquet causes high pressure in the vein, leading to loss of water and the low molecular weight substances, and increases the concentration of protein cells and analytes bound to either the protein or the cells, such as the calcium which we just spoke about. And this becomes clinically significant after a very small time of not more than 2 minutes, within 1 to 2 minutes. That is why we have a window of 1 to 2 minutes during which we should draw the blood and not let the tourniquet remain in position, remain bound to the patient's arm. Immediately the tourniquet should be released. So the time for drawing the blood after tying the tourniquet should be within 1 minute, and tourniquet should be released 1 minute after its application. The ninth factor is the muscular activity. Often we ask the patients to clench their fists to give a prominent vein. So that actually has a very deleterious effect on the potassium levels. Moreover, increased physical activity, like I had said with the TMT testing, leads to a significant rise in cardiac enzymes. If the patient is in the habit of going to the gym and working out the day before or in early morning, he has to abstain from that if he is to give blood for analytes like creatine kinase or CKMB. Otherwise, it will lead to falsely elevated levels, the activity will be very high, and the patient may erroneously think that he or she is suffering from some disease. Intensive exercise leads to enhanced platelet aggregation and false elevation of the leukocyte count, leads to leukocytosis. And if any individual who exercises more than 12 hours a week, significant exercise, leads to a chronic elevation of hormones like the TSH, cortisol, ACTH and prolactin, which if that exercise is reduced over a period of time will lead to normalization of the levels of these hormones. So before preparing for blood sampling, there are some key notes which we have to keep in mind. Proper standardization of the controllable variables. Now, what are those controllable variables? The ones which we have discussed. There are certain interfering variables like hemolysis, icterus, lipemia. Those we have discussed in a separate module in my previous sessions. Those are things which require a different type of strategy to work out. That is, those are the actual interferences. Those are not influencing substances, and we have to take care of them. Icterus, it is not possible to take care of. Lipemia and hemolysis, we can take care of it, provided that they are due to extraneous factors and not due to in vivo factors. Blood should be drawn preferably between 7 a.m. to 9 a.m. when we are talking of morning samples. Morning samples are always preferred. Fasting, they say 8 to 10 hours is sufficient, but if possible 10 hours is always preferred, during which only consumption of water is permitted. Alcohol to be avoided for 24 hours before sampling, and patients should be strictly advised to refrain from smoking and caffeine intake on the morning of sampling, because there are individuals who feel that a simple cup of black coffee or a simple cup of black tea or even green tea for that matter does no harm in the long run of things, and it is giving a sample after consumption of caffeine is equivalent to giving a fasting sample. So they should be properly advised that no, you can't even drink coffee. That is also not done. The only thing you can drink is water, and no smoking on the morning of sampling. There are some unavoidable influences which we cannot control. This table enumerates them. That is age, race, gender, pregnancy, altitude. For example, age has a definite bearing on alkaline phosphatase levels, LDL cholesterol, hormones, creatinine. So we have to provide age-dependent reference intervals. We do that so that as per the age of the individual, the interpretation can be made. Race, it has been seen that creatine kinase is higher in black than in white males. Granulocytes are higher in white than in black males, and creatinine is higher in black than in white males. So we have to provide race-specific reference intervals for these analytes too. Gender, ALT, gamma GT, creatinine, these are all higher in males compared to females. So again, we have to provide gender-specific reference intervals. Pregnancy influences many analytes, leads to increased levels of triglycerides, reduced homocysteine, and depends often on the trimester of pregnancy. So we have to accordingly check for which trimester which analyte is getting influenced. Altitude leads to often hemoconcentration, raised CRP levels, reduced transferrin levels. So we have to see to how many weeks the patient or the person has adapted to the change in the altitude, and whether he's about to go from a lower to a higher or higher to lower altitude. Has he made the ascent or the descent very suddenly and then given the blood? So all this we have to take into account. So that is it. I hope I was sufficiently clear in the presenting. If you have any doubts, please feel free to post your doubts either in the channel or you can address them to me. I'll be very happy to take them. Thank you and have a great day ahead.